Hi friends. So coming to arthritis, when God created this world, what came first, male or female, we don't know. But as he started encountering some diseases, the first disease that came to him was RA. And he followed the rule ladies first. So RA was given to females. And the classical presentation of RA, bilateral hand pain, morning stiffness. Usually they'll give you a history of young female, but now they are coming any age. So bilateral hand pain, morning stiffness is usually RA. As the time went by, the ladies asked God, they called up God and said, what about males? They didn't ask decrease RA. They said, what about males? God said, okay, whatever disease comes next, we'll go to males. And you know what came next? Ankylosing spondylitis. Young man, low backache, decreased chest expansion, ankylosing spondylitis. Classical point, sacroiliitis. As further the time went, females again called up God and said, ankylosing spondylitis does not involve the hand, which is a very important organ which is damaged in RA. And ankylosing spondylitis is much less common, and the disease can be controlled by swimming and cycling. God asked, how do you know all this? They said, it's because of Harrison. So even God accepts the reference from the Harrison. God said, okay, whatever comes next, we'll give it to the males again. And you know what came next? The next thing that came was bone tumors, and they were given to males. Now, males wrote a letter of request. They can't talk to God, so they wrote a letter of request, sir. You have given us ankylosing spondylitis, all the tumors. Do some justice. God said, okay. G for girls, G for GCT. This tumor goes to females. F for females, F for fibrous dysplasia. This again goes to females. So GCT and fibrous dysplasia, these are two tumors which goes to females. Further, subsequently, females again raised the question. Hand is totally destroyed in RA. Ankylosing spondylitis spares the hand almost, and tumors also rarely involve the hand. So God said, okay, let's have a meeting. So God called the representatives of RA upstairs. So 5 of them went, 5 fingers, so 5 of them went. They were all sitting there. God said, let's have one more disease to distribute hand. And the disease was osteoarthritis. So one group of OA was sitting, one group of RA was sitting, and the hand joints had to be distributed amongst them. God said, every finger has 3 joints, MCP, PIP, DIP. So you can spare one joint. RA group was given the first chance. Rheumatoid arthritis, more common in females. God said ladies first. So the RA group was asked to spare one joint. So they said that we will spare the DIP. We will involve the MCP and PIP. Why DIP? Because we have to apply nail polish, and if the DIP is involved, the nail polish will not look good. The thought was different. 4 out of 5 said that, and they took a decision very quick. God said, should I lock it? They said yes. Since that day, DIP spared in RA. Now God looked towards the 5th representative. She was quiet. She said, we did an error. MCP is the major joint controlling the fingers. We should have spared that. But the decision was taken. The answer was locked. God looked towards the OA group. The OA group said, we want to spare MCP. They didn't even know what is MCP. But they said, we want to spare the metacarpopharyngeal joint. Since that day, the MCP joint was spared in OA. So we can remember like this. If you point a finger towards somebody, the two joints that points towards him, OA, DIP and PIP, that's OA. So DIP and PIP, they are involved in OA. And the two joints which are towards you, the PIP and MCP, they are involved in RA. Right? So these two joints are involved in OA and these two joints are involved in RA. Right? But then the RA group said, our fingers are gone. God said distribution is done. They said thumb is left. So the base of first metacarpal was given to OA. It is a classical joint involved in osteoarthritis. Then the OA group said we have been given more joints. And then the wrist was given to RA. So OA, these two joints. RA, the other two joints. OA, RA. Classically, OA spares the MCP. RA spares the DIP. RA, that is rheumatoid arthritis, can involve the cervical spine. And which area of cervical spine? The upper cervical spine. So this is an area. For testing this, you do a flexion, extension, x-rays of the spine to evaluate. So craniovertebral junction, the upper cervical spine is involved classically in RA. Less common in AS. Gout is very rare. Some common joints to remember. RA involves the hand. OA involves the hand, DIP classically, and the knee joint. Ankylosing spondylitis involves the sacroiliac joints, spares the hand and the ankle. Gout involves the great toe. G for gout, G for great toe. And pseudogout involves the knee, remembered by a mnemonic PK. Pseudogout, knee, gout, great toe. The first metatarsophalangeal joint. When I look at an OA hand, in an OA hand, you will have the DIP involvement forming the thickenings called as Hubbard nodes, the PIP involvement causing the Bouchard's nodes, and I told you the classical one is the first carpal metacarpal joint, base of thumb involvement. This is Hubbard nodes. Whenever they will show you an OA hand, they will show you the front view. Whenever they will show you RA hand, they will show you the side view. It's a rule. Psoriasis. 7% cases the joint diseases occur. They will have ossifications, opera glass hand, sausage like disc, cup and pencil appearance. It appears as if there is a cup along with pencil appearance. The joints and the hands are destroyed in psoriasis. OA, I told you, involves the distal interphalangeal joint, more common than the knee joint. When we look at the knee joint, classical signs of OA knee: decreased joint space. Just beneath the joint, there will be sclerosis called as subchondral sclerosis. Extra bone formation called as osteophytes. When the bone gets destroyed, periosteal reaction is there. When the joints get destroyed, osteophytes are formed. When the spine gets destroyed, syndesmophytes are formed. They are the osteophytes of the spine and the cyst beneath the joint. That's how it looks like. Whitening just beneath the joint, normal joint space, decreased joint space, tibial spine spiking, extra bone formation called as osteophytes. When you look at the knee joint, in OA knee, the medial compartment is involved. It undergoes genu varum. Distal part towards the midline. It's like making an O between the legs. Between the limb there's an O. Quadriceps is the most commonly involved muscle, and amongst the quadriceps, vastus medialis, and amongst vastus medialis, the obliquus fiber, vastus medialis, obliquous fibers are involved in OA. When you look at this image, OA knee, O, RA knee, R. And when suddenly at the metaphysio-diaphyseal junction, there is a twist in the tibia. This is called as tibia vera, also called as Blount's disease, about which we will talk later. OA treatment. Any orthopedic condition, first you give a trial of conservative management. Initial treatment is conservative. You will prescribe physiotherapy, lifestyle modification in which you will ask them to reduce the weight, plus they will be taking some drugs like glucosamines. But if in spite of doing this, or patient presents and says, I can't perform the activities of daily living, can't go to the washroom, can't sleep comfortably, you operate it. Surgery in the young, which is up to 60 years, is high tibial osteotomy. So you take out a wedge, lateral base wedge, as you were doing in cubitus varus, and up to 20 degrees were corrected. But if the patient is 60 or more, you will do a total knee replacement, which will give you a normal movement, which will also give you a normal proprioception, can give you mild insignificant sensory loss. Right, so when we treat OA, clinical picture is the most important. Initially conservative, but if patient cannot perform the activities of daily living, you go for surgeries. High tibial osteotomy, less than 60 years, lateral base wedge. You take it out, straighten the excess, but only up to 20 degrees. If the deformity is more, or if the patient is 60 or more, you will do a knee replacement. You will replace the femur, the tibia, and the patellar surface, called as total knee replacement, giving you a good movement. Almost normal position sense, mild insignificant sensory loss along the lines of incision. When you do a knee replacement, sometimes in the extension of the femoral component, means the knee extension, the patella attaches on the femoral area. So the patella will go and get stuck up on the femoral component in the knee extension. This is called as patellar clunk syndrome. The issue is fibrotic nodule at the upper end of patella. Treatment is arthroscopic debridement. OA, RA. Osteoarthritis is a damage to the cartilage and will have genu varum. It will also have sclerosis. RA is principally proliferation of the synovium, synovitis, which damages the joint more on the peripheral area where there is a reflection of the synovium. Plus, there is valgus. Apart from the sclerosis in OA, in fact, in RA, because of more blood supply, there is osteopenia. Because more blood supply will cause bone resorption. So, hollow bones is a feature of inflammatory arthritis. When I look at the criteria for RA, you have two criteria, 2010 and 1987. 2010, 10. Total points 10. So, it is according to number of joints involved. More the number of joints, more the points. So, if more than 10 joints are involved, 5 points are there. RA factor, anti-CCP. These are two antibodies. Anti-CCP is the most specific antibody in RA, present in 98% of cases. If they are high, 3 points. High ESR and CRP, markers of inflammation, 1 point. More than 6 weeks duration, 1 point. 5 and 3, 8 and 1, 9 and 1, 10. Total score 10. More than equal to 6 is RA. Whereas 1987 criteria, 7. So total point 7. A. Morning stiffness, more than 1 hour. 2. Symmetrical involvement. 3. Hand involvement. 4. If There are 7 joints on each side. So total 14 joint areas. If 3 out of these 14 are involved, it's a positive point. What are those? The joints are PIP, MCP, wrist, knee, ankle, MTP, and elbow. So PIP, MCP, wrist, elbow, knee, ankle, MTP. Out of these 7, both the sides 14 areas. If 3 or more than 3 are involved, it's a point for RA. These are 4 clinical points. 5th, pathognomic of RA, rheumatoid nodules. 6th, positive RA factor. 7th, X-ray changes. 4 out of 7 is RA. Let's come to the last line we had done. Bilateral hand pain with morning stiffness is RA. So when you have bilateral, means symmetrical. Hand, one more point. Most of the joints involved, more than 3 joints involved, morning stiffness. So according to 1987 criteria, 4 out of 7 are positive. That's why this is diagnostic line for RA. One more thing. Remember, old is gold. 1987 is a more reliable criteria. When we look at RA, in an RA hand, they will always show you the side view. There will be flexion of DIP and hyperextension of PIP. Why hyperextension? Because there is a flexor defect in this condition. This is called as swan neck deformity. So there is a flexor defect of PIP. Is DIP spared in RA? Yes. In arthritis, there is no arthritis on this joint till the very late stages, but deformity because of the imbalance of the ligaments and tendons can be there involving DIP. Opposite to swan neck is the Boutonniere deformity. Hyperextension of DIP, flexion of PIP. There is an extensor damage of the PIP. Z deformity of thumb. Another thing seen in RA. RA will have ulnar deviation of the fingers. So that is how the metacarpophalangeal joint ulnar deviation occurs. Classical image that came in All India or NEET 2019. Poor prognostic factors for RA. Remember by a movie name, poor movie, Ravan. Positive rheumatoid factor, acute phase reactants, advanced age, 1 year duration, presence of nodules, erosions, and high ESR. So these are poor prognostic factors for RA. Ra1. Some other hands which can be shown to you, pencil and cup deformity. Now that's how this will look like. This is a pencil in the cup, seen in psoriasis. Or resorption of the terminal tuft of phalanges, acroosteolysis scleroderma, or totally deformed fingers seen in arthritis mutilans seen in RA. Now, these were the peripheral joints. Let's come to the axial skeleton. In axial skeleton, when you see sacroiliitis, radiographic, not clinical, you go towards ankylosing spondylitis. This is an essential criteria, modified New York criteria. You have sacroiliitis, picked up best on MRI in the initial stages, more on the iliac side than the sacral, unilateral or bilateral, plus one of the supporting criteria like inflammatory backache, reduced chest expansion, and decreased lumbar movement, which are assessed by Schobert or modified Schobert test. Ankylosing spondylitis is a disease of the ankylosing of the axial skeleton. Peripheral joints are involved in 30% cases. In 30% cases, you will have anterior uveitis. The most common extra-articular manifestation. Ankylosing spondylitis, when you look at this disease, it can have cardiac defects. What exactly it is? It is an enthesitis. At the insertion of ligaments and tendons, there is inflammation. Sacroiliitis is a part of the same. Ankylosing spondylitis, 90% cases will have positive HLA-B27, which is also seen in Reiter's syndrome, Safer syndrome, reactive arthritis. So, these are the conditions where spondyloarthropathy is there. Ankylosing spondylitis, this is a classical image. They will show you a white skeleton. When they show you OA, front view, RA, side view, ankylosing spondylitis, spine. They can show you fusion of multiple vertebrae called as bamboo spine. The vertebrae appear square. They can show you an inverted knife in the center of the vertebral column. It is due to the calcification of supraspinatus and the infraspinatus along with the interspinous ligament. So supra and interspinous ligaments, their calcification, it looks like an inverted knife called as a dagger sign. So in dagger sign, there is calcification of supraspinous and interspinous ligaments. When along with these central ligaments, there is calcification along the facet joints. It looks like a track of a trolley track sign. When there is resorption of the corners of the vertebra, it's called as a shiny corner sign or Romanos sign. In ankylosing spondylitis, radiographic sacroiliitis is diagnostic, but these are the clinical tests which are very commonly asked. You are trying to exert a force on the SI joint and trigger pain. Ganslin's test, Patrick or Faber test, figure of 4 test, pump handle test, and side-to-side compression test. These are the tests for ankylosing spondylitis. Cervical spine, again, is rarely involved, but if you have to remember the test, the flesh test, which is very, very important. Ankylosing spondylitis is known by involvement of sacroiliac joints, whereas a disease seen in elderly, where more calcification of the vertebra seen, called as ankylosing hyperostosis or Forestier's disease, there is involvement of dorsolumbar area. AS is seen in young, ankylosing hyperostosis in elderly. AS, there is marked limitation of chest movement, ankylosing hyperostosis, mild restriction of the chest movement. Calcification of the vertebra. I told you AS is a common cause, but sometimes they give you a history. A patient has urine which turns dark on standing, or any body fluid turns black on standing, called as alkaptonuria, along with the intervertebral discalcification seen in alkaptonuria. This question is very commonly asked. Or there can be hyperostosis called as diffuse interstitial skeletal hyperostosis or ankylosing hyperostosis or Forestier's disease. This image came in one of the exams. Kesara is a variety of Afghani chapati, and this is a way to remember the involvement of eye in RA. Keratoconjunctivitis sicca, more common than episcleritis than scleritis. Whereas in ankylosing spondylitis, it's anterior, A for AS, A for anterior uveitis, the most common extra-articular manifestation seen in 30% of cases. When we look at the inflamed great toe, that's going to be gout. Classical. They will show you erosions around the bone and the soft tissue component. These erosions have been called as the rat bite erosions. Rat bite erosions. And around the head of first metatarsal, there will be overhanging bone, which on the radiology is called as a Martel sign. They will always give you a history of businessman, alcoholic, middle-aged businessman who's alcoholic, because that's one of the components that precipitates an attack of gout. Whereas pseudo-gout involves the knee joint and there is calcification of the menisci, chondro, cartilage, calcinosis, calcification. Gout involves the great toe, pseudo-gout the knee joint. In gout, the crystals are made of uric acid. In pseudo-gout, calcium pyrophosphate. In the gout, the crystals are needle-shaped. In pseudo-gout, they are rhomboid-shaped. If this is a crystal on which you throw a light through a polarizing microscope. So if you throw a light through the polarizing microscope and the light deviates on the left, that's negative birefringent. And if it goes on the right, it is positive birefringence. So in pseudo-gout, you have positive birefringence. In gout, negative birefringence. So gout, protein alcohol intake, erosions. Pseudo-gout associated with catinism or hypothyroidism, chondrocalcinosis. That's what? Overhanging bone around the MTP, first MTP, gout. Also, there's an erosion that you can make out with a history of great toe pain. Charcots. When you look at Charcot's joint, they are also called as neuropathic joints. The joint is totally destroyed. There are multiple loose bodies, right? So when we look at this is a Charcot's joint. Right? Totally destroyed joint, loss of proprioceptive fibers. Some common causes: diabetes involving the midfoot joints, number 1 cause. Taves dorsalis involving the knee joint, common cause. Leprosy involving the hand joints, common cause. Syringomyelia involving the shoulder joint, common cause. When you look at Charcot's, which is also called as a neuropathic joint, there is a loss of proprioceptive fibers. There is total destruction. There are deformed joints. The anatomy is totally gone. Charcot's joint is a spot diagnosis. Charcot's came 4 years back into NEET exam as a spot diagnosis as an image. Treatment: this is a rare condition where you do a joint fusion. Usually don't fuse a joint because fusion will take away the pain but will cause increased pain in a joint above and a joint below. But Charcot's, you do arthrodesis. Hemophilia, one area which examiners just love. Hemophilia will have more blood supply, so there will be osteopenia. So I made a mnemonic, penia, because there is osteopenia. So the patella looks squared, the epiphysis looks bigger, the intercondylar notch, I'll just show you the images, looks wider. There is decreased joint space called as arthritis. There is articular cyst, again an A we can remember. Arnold classification, we can remember A. So if I write down an A here for arthritis, Arnold classification, articular cyst, I write an I doesn't mean anything. I write a wide N, widened notch. I write a tall E, epiphyseal enlargement. I write a P with a square, so it makes a penia. Spelling makes like a spelling of penia, osteopenia. Whenever this question comes, 5 answers are correct. That's how the widened intercondylar notch looks like. Classically seen in hemophilia, can be seen in tuberculosis and juvenile rheumatoid arthritis. There is blood deposition which you can make out on histopath. That's how the coloration will be there, and there will be lytic lesions they show you. This is a histopath appearance that comes with the x-ray sometimes in the exams to pick it up. Most common cause of loose bodies in a joint, osteoarthritis. Most common cause of loose bodies in a joint, OA. Which joint? Knee joint. Most common cause of multiple loose bodies is synovial chondromatosis. Can involve the shoulder, can involve the knee joint. You can see the storm appearance here. So many loose bodies. You can see the knee also. Why there are more loose bodies above the knee rather than the knee level? Because the synovium takes a reflection above it. That's why sometimes the suprapatellar area, you put a needle to aspirate the joints. This is chondromatosis. multiple loose bodies. If there's a varus, between the limbs, there will be an O. If there is a valgus, there will be R. But if, as if the wind is taking the knee, one on the valgus, other on the varus, it's called as a wind-swept deformity. So wind-swept deformity, valgus on the one knee, varus on the other. Synovial fluid, sometimes they get a lot of questions on it. WBC count of a synovial fluid is less than 200 per microliters, and it's a clear fluid. Non-inflammatory fluid is again clear viscous, and the count is between 200 to 2000. Synovial fluid, which is inflammatory, can take the count from 2000 to 50,000. But when you have inflammatory fluid, you have reduced viscosity, it goes down, and diminished hyaluronic acid. Hyaluronic acid is responsible for the viscosity of the synovial fluid. There are two types of cells, type A and type B cells in the synovial lining. Type B cells are responsible for producing the synovial fluid. In pyogenic infection, the counts are high, more than 50,000. 90% are neutrophils. Whereas tuberculosis or granulomatous infections, there is predominance on the histiocytes. The blue areas are the areas which have been asked in synovial fluid till now. Metacarpophalangeal joint. Around this area, there is a one pulley of the tendon sheaths. And if there is a constriction around it, this is called as a trigger finger. The finger locks down. And with a force, you have to open it. It snaps open. This is trigger finger. They sometimes show an arrow on the MCP and ask you which disease occurs here, trigger finger. And then pigmented villonodular synovitis is a benign lesion of synovium, can be seen around the knee joint, and there is a proliferation of the synovium. Pigmented villonodular synovitis.